Hello, my name is Jonathan Durantano, and I am an assistant professor of otolaryngology head and neck surgery at Georgetown University Hospital in Washington, D.C. Today, I will be discussing anterolateral thigh free flap reconstruction. An anterolateral thigh free flap, also known as an ALT free flap, consists of skin, fat, and fascia taken from the lateral aspect of the thigh. This flap of tissue is supplied by branches of an artery called the descending lateral circumflex femoral artery and its associated veins. The ALT free flap is removed from the leg, along with its artery and vein, and then transferred to the area of your head and neck, which needs reconstruction. The flap artery and vein are connected to a similar size artery and vein in your neck in order to reestablish blood flow within the flap. If your surgery requires removal of the lymph nodes in the neck, then the blood vessels in the neck can be accessed through this existing neck incision, and no additional incisions are necessary. If your surgery does not require lymph node removal, then I will use a small incision either under your jaw or in front of your ear to access an artery and a vein. Reconnecting the blood vessels requires meticulous technique, as I reconnect blood vessels having a diameter of approximately 1/10 of an inch, using sutures that are finer than a human hair. These sutures are usually not visible to the naked eye, and surgery is performed under a high magnification surgical microscope. Depending on the complexity of the defect, total surgical time is usually between 8 to 12 hours. The ALT free flap is a very versatile flap that can be used to reconstruct a variety of head and neck defects. The flap is most commonly used to reconstruct defects of the tongue, throat, and swallowing passageway. The ALT free flap can also be used to reconstruct areas of missing skin or muscle, and it can also be used to restore volume to areas of the face. For an ALT free flap, no special tests are needed before surgery. Because we do not want excessive bleeding during surgery, we want you to stop taking any medications that can cause blood thinning. These drugs include common blood thinning medications such as aspirin, Coumadin, and Xarelto, as well as non-steroidal anti-inflammatory drugs such as Motrin, ibuprofen, Advil, and Aleve. In general, Tylenol is the only over-the-counter pain reliever that does not cause bleeding problems, so it is safe to use for the week before surgery. Because you will be under general anesthesia for at least 8 hours, do not eat or drink after midnight on the night before surgery. The reason it is required that you have nothing to eat or drink is that when the anesthesiologist is putting you to sleep for surgery, you are temporarily paralyzed while the breathing tube is being placed. If there is any food in your stomach when you are paralyzed, this can come up from out of your stomach and potentially spill into your lungs, causing an aspiration pneumonia. Aspiration pneumonia can be a very dangerous situation. It's okay to take your regular medications with a small sip of water on the morning of surgery, if so instructed by one of the physicians or nurses, but be sure not to eat breakfast or drink your usual morning cup of coffee. After ALT free flap surgery, most patients spend 7 to 10 days in the hospital. The first 3 days are spent in the ICU. This is not because you are so ill that you need to be in the ICU, but because the flap needs to be constantly monitored by a nurse. Because the biggest risk after free flap surgery is that a blood clot could form within the flap artery or vein, the blood flow to the flap site will be checked every hour by the ICU nurses for the first 3 days after surgery. This is done with an ultrasound probe called a Doppler. Your nurses and doctors will also be checking the color and temperature of the flap to ensure that it is healthy. Sometimes the rounding doctors may prick the flap with a small needle to ensure that the flap is bleeding bright red blood. Rest assured that this prick does not cause any pain, as the flap does not have sensation. The vast majority of complications with free flaps occur within the first 72 hours after surgery. As such, once you are more than 3 days out from surgery, as long as you are doing well from a medical standpoint, you will then be transferred to the routine surgical floor for the remainder of your hospital stay. Once you are on the floor, the nurses will continue to check your flap using the Doppler, but this will occur every 4 hours instead of every hour. If the free flap involves your mouth or throat, you will usually have a breathing tube in place in your trachea to help you breathe without difficulty. This tube is called a tracheostomy tube. Because of swelling that is expected after surgery, your airway could be possibly compromised without a trach. The tracheostomy tube is almost always removed before you go home, and the hole in the windpipe will heal within the first few days without any stitches. For the first few days that the trach is in place, it can sometimes be difficult to speak normally. This is only temporary, and you can still communicate with the nurses and doctors by writing. The initial trach tube that is placed has a cuff or balloon on the end of the tube in case you need to be on the ventilator after surgery. Several days after surgery, we replace the cuffed trach tube with an uncuffed trach tube, and once the uncuffed trach tube is placed, it is generally much easier for you to speak. If surgery affects your mouth or throat, you will be unable to eat by mouth immediately after surgery. To maintain your nutrition and to hasten healing, you will be fed through a tube in your nose. This tube, called the nasogastric or NG feeding tube, will be inserted through your nose into your stomach while you are under anesthesia. Your feeding tube will remain in place until you are able to swallow foods and liquids by mouth. You cannot be discharged home with an NG feeding tube in place. As such, if you are unable to swallow before going home, occasionally a feeding tube may need to be placed into your stomach. This is called a gastrostomy tube, and it is usually placed by one of the interventional radiologists or gastroenterologists. Gastrostomy tubes are temporary, and when you are able to swallow again, the gastrostomy tube can be removed. Yes, we generally encourage our patients to get out of the hospital bed and into a chair as soon as the first day after surgery. And within the first several days after surgery, we will have you working with our physical therapists and occupational therapists to get out of bed and ambulate the halls. To reduce the swelling in your face and neck, we will elevate the head of your bed at a 35-degree angle while you are lying in your hospital bed. There will not be any constricting ties or dressings placed around your neck, as this may prevent blood flow through the arteries and veins of your free flap. We may ask that you avoid certain head positions during the first week after surgery, as certain head positions might pinch off blood flow to your flap. We generally ask that you keep your head in a neutral position throughout the day and night. The donor site on your thigh is closed primarily with sutures beneath the surface of the skin and sealed with staples on top. On rare occasion, the donor site is too tight to be closed primarily. In this case, a small skin graft may be harvested from your thigh and applied to the exposed leg muscle. In order to remove any excess fluid or blood from the donor site, a vacuum drain is placed at the time of surgery. This drain remains in place in your leg until the fluid output is less than 30 milliliters over 24 hours when it is removed at the bedside. The surgical staples are usually left in place for approximately 10 to 14 days, after which they are removed. Once your leg is completely healed, you will have a linear scar running down the length of your thigh. It is expected that you will be sore immediately after surgery, as removal of the flap requires tracing of the blood vessels through one of the large quadriceps muscles in the leg, called the vastus lateralis. However, you can start walking on the donor leg starting the day after surgery. The skin over the leg is often numb after surgery, but this usually returns to normal in about 6 to 12 months. Most patients report no change in the status of the donor leg after surgery, and I expect that you'll be able to walk, run, drive, and otherwise function normally. Like all operations, free flap surgery contains certain inherent risks, including the risks of bleeding, hematoma, seroma, and infection. With free flap specifically, one of the biggest risks is that a clot may form in one of the blood vessels supplying the flap, which could lead to the flap not receiving blood flow. This is called the flap becoming ischemic. Alternatively, a blood clot could form within the vein, and the flap might not be able to drain venous blood away from the flap. This is called venous congestion. In both of these situations, if the clot is not removed and the blood flow is not restored to the flap within a matter of hours, the flap tissue could be irreversibly damaged and die. If a flap dies, then additional surgery is necessary to remove the flap that is not viable and to perform additional reconstruction using either another free flap or possibly a regional flap. Thankfully, this type of complication is rare, occurring in less than 10% of cases, but it can prolong hospitalization and recovery. The ALT donor site generally heals very well and has less risk for complication as opposed to other flaps. However, there does remain the risk that the incision may have poor or delayed healing, decreased sensation over the thigh, or decreased movement in the leg after surgery. Yes, as Georgetown is an academic teaching hospital, residents and medical students are typically present for free flap reconstructions. Residents are physicians who have graduated from medical school, but who are learning the additional skills in the operating room and clinic to become surgeons. While I am always in charge of the operation, Complex head and neck surgery requires multiple sets of hands to be performed efficiently and safely. Once the operation is over, the residents serve as our eyes and ears for our patients who are recovering in the intensive care unit and on the floor. One of our residents is in-house and on call 24 hours per day, so they are always on hand to help manage any issues that might arise. I firmly believe that the presence of residents and medical students in the hospital is a benefit to patient care. We generally start all of our patients who have undergone free flap reconstruction on a baby 81 milligram aspirin to help thin the blood and prevent clots from occurring in the flap vessels. You will take this baby aspirin for 1 month after surgery. You will also be provided with a prescription for a pain medication to take as needed. You will be seen in clinic regularly for post-operative visits. After suture removal, you will be seen in clinic every 1 to 2 weeks until healing is complete. Once you have completely healed, you will usually continue long-term follow-up with your cancer surgeon, and you will see me as the reconstructive surgeon on an as-needed basis.